we've got a whole awesome afternoon of some really spectacular didactics, cutting edge, sort of in the realm of education. And so I'm really excited, first and foremost, to introduce our first speaker of the day, Dr. Hart from Hennepin. Take it away.
Well, thank you. Thanks for having me. And so we're going to kick it off with starting to talk about entrustable professional activities. And so this is the concept here in entrustment is how much do I trust the resident to do X, Y, or Z on their own versus with various levels of supervision. And so today we're going to talk about what EPAs are, how they are similar versus different from the milestones, and how you can use EPAs and milestones in an integrated assessment framework. Now, the big difference here between milestones and EPAs are that milestones are describing the person. So the question you're asking with milestones and competencies is does this person have the ability to provide patient care, to do a focused H&P, to figure out what abnormal vital signs look like? Whereas when you think about EPAs, that's describing the work. Do I trust this resident to do X, Y, or Z procedure on their own versus with various levels of supervision? Do I trust this resident to go run a resuscitation or provide critical care on their own? And if not, what level of supervision do they require or should they have for these work-based activities? And so these are decisions that you guys as supervisors have been making forever, right? For your entire career. You make these decisions every day, multiple times a day. Should I let this resident or this student go do X, Y, or Z on their own? And if not, how much supervision do I need to provide? Do I need to be there the whole time? Can I pop in and out? What is appropriate for their level of competency at this point? Thing doesn't seem to like to advance. And so how do you document those decisions? So EPAs have these levels of entrustment. There's level 5 we're not going to talk about, which is supervising junior learners. But for your purposes of assessment in the workplace, you can think about these various levels. So are they not able to do it at all, right? Is this a first week intern who you're like, okay, you're not going to be running resuscitations yet, right? You're not going to be in charge of that resuscitation. Is it a level 2 where they can do the activity, but they need direct supervision? So that means you're in the room, kind of looking over their shoulder with them the whole time, giving them coaching and feedback throughout and helping them out. Is it a level 3 where they can do it with indirect supervision, meaning you may be out at your computer, and this we do a lot, right, with our patients who are lower acuity. You're kind of doing your own thing there, and they're doing the H&P, coming up with a differential, deciding what they're going to order, what test they want, what diagnosis they think is likely. And then you guys talk about it. You may go back in the room and repeat a few key parts of the history and exam, but you're not with them the whole time, and you're giving them kind of guidance at a little more distantly. Or are they able to do it independently? So would you say, okay, I'm okay if this resident says, hey, I want to go moonlight in a place where I would take care of patients like this, and you said, cool, I feel totally fine with you moonlighting and doing this stuff on your own, right? In our emergency department, this is a little bit less applicable because, of course, we see all the patients that come in, right? We need to see all of our patients. That's just generally how it works at most places. But if you'd be okay with them doing it independently, then it would be a level 4. And so you may be saying, okay, well, that's really nice and sounds fine, but we already have these milestones and we have to report them to the ACGME every 6 months. And so why do I want something different to do? I don't want another thing that I have to do. And what I'm going to tell you is how these things are kind of integrated and linked to the milestone so that you're not actually doing something else. Your EPAs that you're assessing will be linked to the milestones on the back end. And so your CCCs will still get all the milestone information they need, while you'll be able to document the decisions that you're making in the way you've been making them for a long time. And so this is how milestones and EPAs kind of relate. So multiple milestones contribute to any one EPA. So if you think about taking care of some sort of patient, right, you need to integrate some patient care competencies, some interpersonal communication skill stuff, some professionalism stuff, some systems-based practice stuff, right, to take care of one type of patient in your emergency department. And so in a little bit more detail, it looks like this. For any one EPA, you have a number of domains of competence, right, which is what we've been calling core competencies for a long time. right? These are patient care, interpersonal communication, systems-based practice, et cetera. So for any one EPA, you're using all of those domains of competence. Within them, then you're looking at the sub-competencies. And you're saying within patient care, right, we've got like 14 milestones or milestone chunks that talk about patient care stuff. So what goes into that? They need to be able to do an HMP. They need to be able to come up with a diagnosis. Within interpersonal communication skills, they need to be able to talk to the patient. They need to be able to talk to the healthcare team. So that integrates multiple milestones in the ICS domain. And then within systems-based practice, they need to know what the system is, how to work within it, how to get your patient follow-up. They need to then document in the EMR, right? And so that's the technology SBP milestone. All of those are integrated into taking care of any one type of patient in your emergency department. And then beyond that, we look at what individual milestones are linked to those EPAs. So not just what subcompetency, what group, but which individual ones from which level are linked to that EPA that we're talking about. And so we did this. I did this with a phenomenal group of collaborators a few years ago. It was just published in WestGen this past year, of how do we create a list of EPAs for emergency medicine and then link all of those milestones back to those EPAs. So we came up with a list of 11 EPAs that work for emergency medicine. These are just the first 3 as some examples. And we're going to take the first one and kind of walk through how would I use that on a clinical shift using this as a workplace-based assessment tool. So with your low acuity, low complexity, stable patient, which sub-competencies go into that, right? All of these. I've got 6 patient care sub-competencies that are required to manage a low acuity, low complexity, stable patient, in addition to those other things that we talked about, right? Communication, professionalism, SBP, et cetera. And so we said, okay, now we've got this premise, we've got all the milestones linked in this big, huge document. How do we actually employ this, right? How do we use this in clinical practice as a workplace-based assessment? So we came up with these shift cards, which tends to work well in emergency medicine in general. And we said, you will pick the shift card that is most related to the types of patients you saw with that resident day. So you're not doing 11 EPAs every shift you work. You can pick one EPA, right? Okay, hey, I was in fast track. I'm going to do low acuity, low complexity, right? Versus, oh, I was in our resus bay, right? I'm going to do high acuity, high complexity today. Or you could do more than one if you wanted to. And so the way this works is that you would first assign their level of entrustment. So for low acuity, low complexity, it's going to be unlikely that you're going to give them a level 1 or a level 2, right? You're not going to say my resident can't see an ankle sprain, and you're not going to say I need to stand over their shoulder the whole time they're doing an HMP on an ankle sprain, right? That's unlikely, and so for this we grade those 2 out, acknowledging you're not going to use those very often. So then you have level 3 and level 4. So if you said level 4, this person, okay, this is a graduating G3, right? They've got this low complexity, low acuity thing down. Cool, they can do that independently. I'd be okay if they went and did that in urgent care. Then you move down to the free text box, and you can just put whatever comments you want in there. If you go to level 3 and say, okay, they need indirect supervision, right? They still need some help. We need to talk about the patient. I need to go kind of re-ask some of the key questions. Then you follow the arrows down, and you say, what should they work on? Do they need to work on data gathering and medical decision making, or do they need to work on communication, professionalism, or system stuff? We separated these for 2 reasons. One is that we wanted the groups of KSAs that you get to next to be a reasonable size, right? To be like 10 each. If I gave you 20 or 30, people would be like, yeah, right, I'm not filling those out. So we made them reasonable size, and we wanted to make sure that we called out communication, especially, as an important part of what you need to be able to do to be entrusted. Because as we talked about, we said, you know, this could probably get overlooked, right? You're like, okay, he's kind of mean to the patients, but he does all the right things, so whatever, it's fine. We wanted to call out that you needed to be able to do all these communication things well to reach an entrustment decision. So for each KSA, so knowledge, skills, attitudes, abilities, for each KSA that relate to those EPAs, those are all linked to milestones on the back end. So on your assessment sheet, you would see the things there on your left, right? What are the items that they need to do in order for me to say, I trust you to do this thing on your own, right, out in an urgent care. And then on the back end of a software system, it would link those KSAs to the milestones. So the grand plan is you input the stuff on the left, the computer system would then take it and output both an EPA-related report and a milestone-related report so that your CCCs and anyone else who wants it also has that information. And notice a lot of the KSAs are linked to multiple milestones, right? So for the first one, reliable and thorough H&P, you need to be able to do PC2, which is the H&P one. You need to be able to do PC4, which is diagnosis, right? You need a differential diagnosis to ask all the right questions in the first place to get all the information that you might need to decide what to do with that patient. And then ICS is the patient communication one. So does it make sense how kind of a bunch of milestones are linked to any one KSA within any one EPA? Awesome. Same thing with the communication professionalism ones. Once in a while, they're just linked to one milestone. Most of the time, they're linked to a handful of milestones. And so if we go back to our assessment end of shift card, once you get down to that KSA box, you get to check any of these. So either, yes, they're doing those KSAs, right? Yep, they got it. Or you may check not yet next, meaning that's what I want you to work on next, right? You've got these 5 KSAs. I want you to work on this 1 or 2 on your next shift. And then, or you could check down the road. So for example, there's one in low acuity, low complexity that is cost-efficient care, cost-conscious care, right? Maybe the first month of your new interns, you don't want them working on cost-effective care, right? So you say, yeah, eventually I want you to get to this, but you don't have to do it right now. So that one's kind of down the road. So this then turns into both an assessment of learning for your program, but it also is an assessment for learning for your resident, right? By filling this out, you've just checked out or checked off and told them what you want them to work on during their next shift in order to move closer to that entrustment decision. Does that concept make sense to everybody? See a bunch of head nods? Perfect. Awesome. And then if you checked level 4, they could do this independently, that would, within the system, check all of those KSAs as yes, right? If you say you're good enough to do this independent, then you're doing all the KSAs related to it. So now how many times do you need an EPA to be checked off as independent before you say, yeah, that's good, you are officially entrusted to do that thing? Or how many times do you need the yes checked off in your KSAs for you to say, okay, I'm good to check that one off on the milestones to the ACGME? And the answer is we have no idea, right? This is part of our current work to do. We don't know what this answer is yet, but there's a handful of different concepts that are going to inform the answer to this question. One of which is OPAs. So Eric Worm did a bunch of work with this in internal medicine, and OPAs are smaller things that are related to every EPA. And so in this example of low acuity, low complexity patient, your OPAs may be seeing a patient with low back pain, seeing one with ankle sprain, seeing somebody with a rash and managing them. So they're smaller elements of work that are related to the larger EPA. So you probably want a handful of different OPAs that resident did to officially say, yes, they're good for the EPA. And that's why we have that list of chief complaints at the top of our assessment form. We want you to write in what those chief complaints were so that we know not only can the resident see low back pain patients and be fine, but they can also see a variety of other complaints before we say, yeah, you're good with a low acuity, low complexity patient. There are also a number of other factors that go into entrustment in general. And so it's not just the type of patient, which we've talked about, but there's a number of characteristics that are more related to the resident. So how long has a resident been in training, right? Have they had a bunch of experience, or are they brand new? That's going to impact your ability to entrust them with whatever. How is their level of competence compared to their level of confidence, right? If those are pretty aligned, you're more likely to trust them than if you say, okay, this person has really high confidence, but lower competence, right? If you say this one's overconfident, you're going to be less likely to want to trust that person. So are those two things aligned? Does the resident ask for help at appropriate times? Do they take responsibility for their patient care and all aspects of it? All of those are going to influence your ability to trust that person to do that task independently at some point. The environment. So there's a lot of aspects of the environment that may affect entrustment as well. So is it a slow shift, right? Maybe a certain resident can do really well with a low complexity patient when they've got 2 or 3 patients at a time, they've got time to think about it, talk to the patient for a while, but once now they get 5, 6, 7 patients at a time and they're trying to be more efficient, maybe it's harder for them to do that. Or maybe they're getting a lot of other distractions for other reasons. They've got a critically ill patient and the nurse is interrupting and asking them questions. So there's a lot that has to do with the context and the environment that will also impact your entrustment. The faculty impacts entrustment, right? How competent is the faculty in that area? How comfortable is the faculty with supervising learners in general? What is that faculty's propensity to trust in general? Right? So you know these people, you all have them. You've got a whole spectrum of faculty. Some are way more likely to trust and some are less likely to trust. Right? You've got the more likely to trust guy who disappears for 3 hours and comes back and is like, yeah, whatever, that's cool. Right? And you've got the micromanager who's like over everyone's shoulder, constantly micromanaging all their patients. That all has to do with their propensity to trust, and those are all going to impact what their eventual entrustment decision as well. Also, the faculty-resident relationship. How well do these people know each other? Have they worked together a lot before, or is it the first time that this faculty and resident have worked together? In which case, they'll be less likely to trust somebody that they've worked with for 4 hours as opposed to somebody that they've worked 25 shifts with. Does the faculty and the resident have a similar practice style? Right? So, of course, there's a spectrum, right, from the people who do a lot of tests to the people who don't do a lot of tests, right, do very few tests. If the faculty is someone who likes a lot of tests and the resident is someone who doesn't get a lot of tests, that faculty is less likely to trust that resident, right, because they think they should be doing more tests. So is their practice style aligned? That also impacts entrustment decisions in general. So lots of things go into this decision beyond just the resident's competence. So in the end, you want a number of different patient chief complaints in a number of different contexts by a number of different assessors before you make any sort of final entrustment decision on any of these. And so what are our next steps? We developed EPAs. In the process of developing them, we have some face and content validity there. So within our group that we developed them, those were all emergency physicians who said, yeah, these all look good, right? We think these are good. Then we had a couple reactor panels. So one reactor panel was emergency medicine educators who looked through them all and said, yeah, on its face, those look reasonable. And we had a reactor panel of folks in the EPA world that were not emergency medicine physicians. So from both ends, we had people reviewing these, providing us feedback, and letting us make modifications on them. Other types of validity that we're trying to collect going forward, or validity evidence, I should say, is reliability. Right? Do we want to have inter-rater reliability on these? And I would actually argue you don't want perfect agreement because of all those factors I just talked about. But you probably want moderate to strong agreement, right? It shouldn't be like weak or non-existent, but it's not going to be perfect because of all those factors. We want to make sure that there's some discriminant validity there. If you assess a G1 and a G3 on the same assessment tool, who are where they should be, the assessment should come out different, right? And so we want to make sure that's there. Maybe convergent validity is something else to look at. Do these align with other things that we're using as assessments for our residents on which we make progression decisions? So there's a lot of things that we still need to look at. And what's the feasibility of using these as shift assessment tools? We also need to think about our rater training. So what is the optimal faculty training for these to get them to use them the way that we're envisioning them being used? How much training is necessary? We've started piloting these at our shop, and as I'm sure a bunch of you know, people don't like to check no on things, right? They're fine checking yes, and they're fine checking NA, but they won't check no. So we said, oh, hey, we're going to do this like not yet next and down the road, this like growth mindset thing. Maybe they'll check those. They don't like to check those anyway. And so we need to train the faculty and the residents, right? You should be checking this because this is how they know what to work on next. And to tell the residents, this isn't a problem if you don't have all yeses checked, right? This is telling you what to work on your next shift, which is actually exactly what you're looking for. And then we need to figure out what is this software program that can host all of this? Do we need to design one? Is there one out there that can already handle this, where we put in the EPAs and the KSAs and it will spit out both that report as well as the milestone report for your CCC so that everyone has the information that they want? And the residents can use whichever one they find most useful, right? Is the EPA one or the milestone one more useful to them? Well, they'll have both, so they can use whatever is most helpful to them in their learning. So in conclusion, You've got EPAs, which are essentially a way for you to document all of those trust decisions that you've been making over and over again on all the shifts that you work with learners. And now that we've created a way that the EPAs can be linked to milestones, we can use those without creating extra work for the faculty assessors, the CCCs, or other folks. And with the assessment or the shift card that we've come up with, you can use those as not just an assessment of learning, but also an assessment for learning by checking which things that the residents should work on the next shift, which will allow them to know what to do to move towards that next level of entrustment. That's what I got. I'm open for questions. Yeah.
I'm interested in your point about sort of faculty being that final common pathway of how do you think there is a future for the EPAs demonstrating competency or growth around a resident and helping non-trusting attendings be more trusting?
Sure, I think that's a great question. So I'm supposed to repeat the question, which is essentially, I guess how I'm interpreting it is, could we do faculty development around helping some of the attendings with this wide span who aren't willing to trust in general? Could we use some of that EPA stuff to inform our faculty development initiatives in order to kind of help bring the faculty, narrow the faculty's preponderance or ability to trust or desire to trust so that that's more uniform? And I think the answer to that is yes. I think we can kind of take this stuff, take the data we get, and say, you know, this resident over the past 3 months has gotten super variable evaluations on this, and what is the reason for that? Is it that it's, and then we just kind of have to delve into, is it the faculty's preponderance to trust? Is it environment? Is it some other things? But absolutely, I think we could use it for faculty development and try and narrow that a bit. Yeah?
Yeah, so I just want to kind of flip this a little bit from the assessment point of view, which you covered very well,
Yeah.
to the learner point of view.
Yep.
So in undergraduate medical education, the key thing is active mastery learning, right? You get the data, and then you get together in a small group, and you go over it, you know, team-based stuff.
That works.
And you're to acquire the mastery of the material, and the ways to go about it. And then we put them in an environment where it's, we are basically observing them do a task, okay? And how good are they at acting at this task? And they could be fooling our noses, right? And it is subject to opinion, and it doesn't really show mastery. And so the question is, and I know this goes to all competency-based education, which I have a problem with, how do we demonstrate mastery within an EPA model?
Yeah, I think that's a great question. So another really important part of education is how do we show mastery and stuff? And I think that this helps the resident get the feedback. So we think about this as like deliberate practice, right? Each shift is an episode of deliberate practice where they get feedback on what they did, and then they come back to the next shift and they try it again until they get to mastery. So that's kind of how I see this. And if I conceptualize it that way, this then does contribute to your mastery model.
You're using that as a tool to get to that deliberate practice.
Correct. Because on this tool, you're giving them the exact feedback of what did you do, what KSAs did you do, which ones do you have to work on next. So they can come back and work on those next. Those will then transition to yeses, right, until they get all of that not yet next, worked on, moved over to yes, and then kind of that will lead to mastery of that concept or whatever that EPA is. Yeah.
So my question's regarding the similarity of EPAs that are being designed for emergency medicine to those of other subspecialties. So I think one interesting thing about the Milestone project is that it was very similar milestones with different anchors, but they were kind of changed slightly for each individual subspecialty. I think now with EPAs, there's ones now in undergraduate medical education and then independent groups that are coming up with them. And I guess my question would be, how similar would this be in design and assessment utility to other programs that are also doing EPAs for other subspecialties? And is it going to be similar, how the milestones might be similar to other subspecialty groups?
Sure, I think that's a great question. And so part of when we were developing the EPAs, we had a lot of discussions on lumping versus splitting, right? How many things do we lump together versus how much do we kind of split apart? I think the more you split, the less applicable they become to all specialties. And so we kind of fell on the lumping side of things, and I'll just show you as part of the answer to your question our 11 EPAs that we came up with. And so these, I think a number of these could be used in other specialties, potentially not every single one, but I think a number of them could be broadly applicable then. So I think it just depends on how you develop your own set of EPAs is how that question's answered. Other questions? Yeah.
Yeah, so this relates to the putting the competence and the confidence together. How do you deal with residents who have low competence but extremely high confidence?
The age-old question. So I think that the answer to that is dependent on the reason that the resident appears to be having a higher confidence level that they should. And so it requires sitting down with the resident and talking to them about, you know, hey, this is what I'm hearing. This is how you've been perceived by some faculty members, and I'm wondering what your thoughts are on this. So now I'm kind of like moving into the like feedback, difficult conversation realm, because a lot of times the answer is not, I'm super confident and I know what I'm doing, right? Maybe that's once in a while the answer, but there's a whole range of answers. Sometimes it's that I'm actually underconfident and I'm trying to kind of compensate for that because I feel like people want me to act confident. There's a lot of different reasons underlying that, and so before I can come up with a solution, I have to understand the reason, and then we can build the solution based on the underlying reason. Does that answer your question?
It does.
Okay.
Raises other ones, but.
That's a whole different talk, and I'm happy to talk offline too afterwards. Other questions? Probably right around running into the end of the time frame. So thank you guys very much. If you have other questions, feel free to get in touch with me. If you are some sort of like software tech whiz and you have an answer to what kind of computer solution we should use to kind of do this big data, also get in touch with me. I am not that computer whiz, so anyone who's got that interest or expertise, I would also love to talk to you. Thanks.